pace a little bit if you guys do not mind. I think you have demonstrated that your minds are refreshed and you remember all the stuff that Ms. Davos taught you over the last few weeks. As we go through this, I will use terms that may be a little refreshing for you. If you don't understand them, please raise your hand. This is the time for you to have me clarify anything that I have on the slides. Because if you don't, these very terms will show up on your test, right? And that will not be the time for you to call me over and ask me, what does hallux rigidus mean, right? I'm going to just refer you back to the words on your page, okay? So, anything that we need to go over or clarify from yesterday's class? Okay, if you ask a question and I don't answer your question sufficiently for you, right? And I try to reiterate the question so the rest of the classes will hear it and at least learn from it. Just let me know, and I will do my best. And if I can't, then I'll have you come see me, and then we can have a good discussion about it. Okay. So we're going to get into a little more foot and ankle pathology. We'll talk about metatarsalgia, plantar fasciitis, plantar warts, posterior tib tendon dysfunction, sesamoiditis, and some toe deformities, right? Hammer toe, turf toe, that kind of stuff. And then we'll end this block with turf toe and then get into the other block hopefully in the second half of the class. So, the name says it all, right? Pain in the metatarsals, and this pain is usually at the metatarsal head. So, patient comes in, they're complaining of pain at what we would normally call the instep of the foot, for those of you that play soccer, okay? That's where that pain is mostly located. You see on your diagram, we talked about the phalanges, we talked about the metatarsals and the tarsals. The pain is at the head of the metatarsal. It's not at the metatarsal base. You have to be able to make that distinction because you will misdiagnose a patient if you confuse where the head or the base of the metatarsal is. Most times it is within the lesser metatarsals, so metatarsals 2 through 5. In a lot of cases, if they have pain in the first metatarsal, which is the big toe metatarsal, then it leads to a different diagnosis, right? In a lot of cases, it's caused from just the weight-bearing forces, right? So you may have other toe deformities. It may be that that person is a little bit overweight or just from regular overuse based on their job. Poor fitting or poorly soled shoes can also cause pain in the metatarsals, right? Every time they walk, there isn't enough flex in the sole, and that just causes pressure on the metatarsal head. What happens when you have repeated is not a word, right? When you have repeated trauma or injury or insult to a part of the body responds by building up tissue in that location. And actually that's how bones heal, right? Because you build up additional bone around the fractured part of the bone. Same thing with soft tissue, that's how you get calluses. And so when you look at the patient's foot, you may end up seeing some calluses at the sole of the foot in the region of the metatarsal heads, right? That pain might be increased with activity, and most times they may come in saying that they feel like they're walking on pebbles. This is different from what we talked about in a Morton's neuroma, where they felt like there was this single marble inside of the foot. That can be a differentiating factor. If you look at the picture on the bottom part of the slide, and you see that callus buildup, right? You see multiple calluses build up in that area, then that is an indication for what's going on with that patient. Okay? On physical exam, we do the same thing that we do for every orthopedic exam, right? First, you want to watch them walk, so you look at their gait, then you inspect it, right? You look at it, then you touch it, palpate it, and once again, not with your spirit fingers, but you actually palpate, trying to feel the structures beneath, right? Then you do your range of motion, and then your special test. I promise you, if you adopt that little formula, you do it the same way every time, more than likely you won't go wrong. Okay? Worked for me, it worked for the people that taught me how to do it, so I'm assuming it's going to work for you. Free education for you. Right? That callus might be a little tender, right? In some cases, you can actually shave down some of these calluses. They look kind of disgusting, but that's what we do, right? We do disgusting things. And so you have to shave down the callus, and it helps to relieve some of the pressure on the patient's foot, right? Now, are plain films indicated in this patient? They can be, because there could be other things going on in the region of the metatarsals, right? So plain films, this is a clinical diagnosis, so you really don't need plain films. However, if you suspect something else, plain films are not unusual. You can still get them. And then those plain films will tell you if there is anything going on with the actual bones. Okay. Non-operative treatment, as for any or most orthopedic injuries, is NSAIDs, activity modifications, some physical therapy. If it pertains to the foot and it pertains to the toes, 9 times out of 10, or maybe 8 times out of 10, you cannot go with modifying their footwear, right? Have them wear better shoes, right? Just as we talked about with the other foot conditions. When all of that works, or when all of that doesn't work, then send them to orthopedics, and then we do some sort of orthopedic procedure. The main thing that you have to know about these is when to refer about the treatment, right? And you refer when non-operative management suddenly fails to work and the patient continues to complain of symptoms. Questions or comments? You have to be careful when you're applying these gel pads, or even you make a makeshift gel pad with more skin, etc. Because if you put it directly over that area of increased pressure, all you're doing is compounding the issue, right? And you're not really helping the patient. You'll come back with more pain. And so in some cases you can cut a hole, right, to account for the head of the metatarsal. And that tends to release some pressure. Okay. Plantar fasciitis. This you will see a lot in the military, because maybe not so much now since we have improved footwear, but in the old days this was very common because the boots that we wore did not lend themselves very well to taking care of your feet. Okay? Most times patients with plantar fasciitis, they tell you the pain is worse in the morning, and then they have to kind of work it off as it gets better throughout the day. But then it gets worse after they walk around throughout the day, and is a little bit relieved by the time they get to go to bed. Okay? There's the area that you see in white here. Okay, that's called the plantar fascia, and it originates from the base of the calcaneus, right, plantarly, and then fans out all the way into the heads of the metatarsals. Why is that important? That is important because that structure is what sometimes helps to maintain the arch of your foot, and we'll talk about that in a second. Now, in most adults, their pain is usually about 1 to 2 centimeters in front of the attachment of the calcaneus, right, or proximal to the attachment of the calcaneus. That pain can be very pinpoint, so if you, as you do your palpation exam, you can actually reproduce that pain predictably by compressing that area. In the old days, we used to do you find that point of maximum tenderness, and that's where you do your plantar fascia injection. Okay, just one way of taking care of it. In some cases, this can develop into what we call a plantar fibroma, or then the patient has a condition known as plantar fibromatosis. But that's when this goes on for such a long time and it remains untreated. So when a patient goes to bed or when they're at rest, the foot generally wants to rest in plantar flexion. right? The foot generally wants to rest in plantar flexion. Why is that? Anybody?
Of the sleeping, contraction of their calf muscle.
Exactly. So we talked about the Achilles tendon yesterday, right? The way that the calf contracts, right, or it relaxes, pulls up on the Achilles tendon, pulls up on the calcaneus, and now the foot goes into plantar flexion. Okay. What's another word for plantar flexion? Start with an E. No? Well, extension. Ah, you got it. Yes. Right? There's another word. It's called equinus. Did we talk about that yesterday? No? All right. We'll talk about it today. So in some cases when after you do surgery and the patient is laying relaxed in bed, the foot drifts into equinus, and that's what you don't want, right? Because all it does is create more tension on the calf, create more tension on the Achilles tendon, and then it becomes difficult to get them back into neutral, right? In the normal resting foot, as you can see in the picture on the far right of your screen, right? See how that foot drifts into plantar flexion? That's generally the normal resting position for when you sleep. Okay? And so with the foot like this, when they wake up in the morning, then what you have is as they step and the foot goes back into neutral or back to 90 degrees, then you have all that tension on the plantar fascia, have tension on the calf, which is why it kind of hurts more in the morning when they wake up. And we talked about that point of maximum tenderness, which is 1 to 2 centimeters before proximal to the insertion of the plantar fascia on the calcaneus. Okay. That increased pain that you get with dorsiflexion of the foot is what we just described as the patient continues gets up to walk first thing in the morning. Okay. I think later on we'll talk about the windlass mechanism. Don't worry about it for now. I will tell you now that I won't test you on that, and it's just something good to know. Okay, so what sort of imaging would you get for a patient that presents to you with what you suspect to be plantar fasciitis? AP lateral, oblique. Which one?
AP lateral. Weight bearing.
Weight bearing, yes, that's good. A weight bearing what? AP? Lateral, right? Checking to make sure you guys are paying attention. That's a lateral x-ray like we talked about yesterday, right? And so what that does, it shows you, in this case, this patient developed a heel spur, right? You will see those on your x-ray. The presence of a heel spur on x-ray does not mean that the patient has plantar fasciitis, okay? However, if a patient has plantar fasciitis, it is likely that you might see a heel spur, especially if it's chronic. The reason for that is, as the repeated contraction of the plantar fascia and the calcaneus, you have these micro tears or this micro trauma to that area and the constant deposition of new bone, which is why you end up with a heel spur. Okay. Now, back in the day, we do repeated injections into that area, right? What is a side effect of using steroids on tendinous structures? Ruptures, right? Nonetheless, if this thing ruptures, right, remember the mechanism we just talked about, right, is that constant trauma and pulling on its attachment. So if it ruptures, the patient immediately feels a little better, right? So then we didn't really mind if you had a rupture of the plantar fascia. However, that's not what you want, right? Okay. Questions or comments on this? When would you refer this patient to orthopedics or podiatry? Say again? When non-operative treatment fails. Yes. Will you ask that question?
No, sir.
Okay. Okay. Questions or comments? It's good. So, as in most orthopedic conditions, right, NSAIDs, activity modifications, modifying the footwear with either some orthotics, right? In some cases, you can use a night splint, which helps to keep the foot in neutral while they're sleeping. And so when they wake up in the morning, there's not that excess traction that causes heel pain. Okay? We talk about injections. You can either do your injection approach from the lateral or medial edge on the medial side of the calcaneus. You will see some folks actually go through the bottom of the foot. That is ridiculously painful. I do not recommend that you do that. Your patients will not like you while you're doing this doing this procedure. Okay? But I do feel if you mix that steroid with some lidocaine, then it does help. Shockwave is actually good, and that is done. Podiatry does this quite a bit, not so much for us in orthopedics, and that has worked well for some folks as well. Okay. And that picture on the top left is what the night splint sort of looks like. It wants to look like a cam walker, right? That big boot that I showed you for in one of the other conditions. But this one is flexible, so you can either tighten it up and make some adjustments as you go along. Yes, sir.
Sir, you said for the steroid injection, to probably try to avoid doing that. So would it be appropriate for us to refer for that injection? You
can, right? I don't think any one of us will push back if you said, "Hey, I tried a steroid injection and it didn't work," right? In my own practice, and even as a primary care PA, we probably do 2 or 3, and then if that doesn't help, then we refer them. But we refer just for the simple reason that they have the side effect of the steroids, right? So, yes. And when would you refer? Would you refer after 1 injection or wait till after multiple injections?
Yes. The Botox injection, would you do that in the same spot, or are you trying to relax the muscles and both?
Yeah, so this is different from the Botox that you face that makes you look pretty, right? This Botox injection is one that actually relaxes, that's supposed to relax the tension in the muscles around the tendon, right? And so the injection is the same. If you were to inject just around the calcaneus and the injection didn't get down to the plantar fascia, it would do nothing for the patient. Because if you think of the mechanism, it's not the muscles that's, the tension on the muscles that's causing the problem, right? It's that traction from the plantar fascia. Good question. Plantar warts, right? So these are hypokeratotic lesions that are caused by the HPV, the human papillomavirus. They can be very prolific, right? You can have 1 lesion, or you can see, as in this case, you can have multiple. Young athletes typically get them because they are out in, playing sports. They get into the same bathrooms in the gym, walk in there without shoes, and before you know it, then they come up with some plantar warts, right? They can be debilitating if there's a whole lot of them, right? But in most cases, they're not. Just unsightly, right? When they get really bad and they flare up, they do cause a little bit of pain. Right? So just be mindful of that. This mosaic of warts like this, you can sometimes have seen patients that their entire foot is just covered with these warts. Right? Doesn't look great, but it's worse for the patient. Now, when you see these things on the weight-bearing portions of the foot, that's when the patients tend to want to come in because then it becomes more painful for them to walk on, right? When you pare down these warts, right, so you get a scalpel, hopefully you cleaned it well, and you kind of remove the top skin, which is what we call paring down. And then you might see some little punctate lesions and some little what looks like micro bleeding areas. That's how you can differentiate between planar warts and calluses, because calluses don't do that. When you pare down the callus, the undersurface is a little smooth and shiny, sort of, right? Planar warts, you get this punctate looking bleeding situation going on. Okay. So, if you're going to apply, use your liquid nitrogen to apply some freeze therapy to it, I highly recommend that you pare it down first and then you apply your liquid nitrogen. This is the diagnostic test for it, so that's your histopathology. But once you pare it down, you either send it to the lab or you can take a slide of it, go to the, if you have a little lab room at your clinic, and then look at it under the microscope. But this is a clinical diagnosis, so 9 times out of 10, you really don't need anything else to apply the treatment. Again, you're applying some liquid nitrogen, right? Using your electrocautery. After paring it down, occlusive tape usually works. Some people will tell you take duct tape, you put it over it, leave it there for a couple of weeks, or you do that application for a couple of weeks and then it goes away, kind of like you do with other warts. Depending on where you come from. I hear this more from folks from the South that say, hey, that's what my grandmother did, and swear by it, right? PAs are a weird bunch of people. All right. It may take some time for this thing to go away, right? In cases when you do nothing, in some cases they disappear on their own. So, but if it's certainly troubling to the patient, then by all means, go ahead and hit it with some liquid nitrogen, carry down, use some liquid nitrogen, and that helps to get it to go a little faster. Okay. Questions or comments? If you pare this down too deeply, you start cutting into healthy tissue, and then it will really start bleeding. Okay, so just be careful when you do it. Posterior tibial tendon dysfunction. Right. So yesterday during our anatomy review, we talked about all the structures that run around the ankles. Now, in the case of the posterior tib, right, it follows its course and inserts on 2 locations on the navicular bone. Okay? You can find this, or you can palpate it, right? More than likely on the, not more than likely, but you can palpate it on the medial side of the ankle, and just follow its course to the bottom of the foot, where it will disappear as it dives deep into the tissues and the interosseous muscles in the foot. Most times, patients with middle-aged patients are the ones that present with posterior tib tendon dysfunction, or for patients or females that are sometimes heavyweight or older, right, over 50. Easiest way for you to as a good marker for this is to look at the too many toes sign. So you have the patient stand, if you look at the left foot, right, in that uppermost picture, and then you can see the protrusion of the small toe and maybe the big toe, right? As the foot goes into pronation because of the dysfunction of the posterior tib, you get the thing called too many toe sign, in which case you might see the middle toe, the third, fourth, and fifth toes, right? Just have the patient align their feet as close as possible in neutral position, and then that's easy to recognize. You have to be able to differentiate, because a patient like this has a, what we call pes planus, right? We were talking about this yesterday. So now the foot is in a little bit of pronation, right? And so if it's a heavy set patient, you have to wonder what else is going on with the patient, right? In cases where the patients are at risk for things like diabetes, then is the patient having a Charcot's foot? Is it the early sign of a Charcot's foot? Is the patient's arch collapsing? So all these questions you have to take into consideration, all based on your patient's diagnosis and your patient's history. Clinical symptoms, usually some pain, a little bit of swelling, loss of arch, right, as the foot goes into plantar flexion, and sometimes a little bit of external rotation, right, based on the what you call it, on the activity level of the patient. In the face of trauma, it's pretty obvious. When there is no trauma, then you have to consider if something else is going on. If you don't treat this, then what you have is persistent abnormal gait, and then of course all of this turns into potential osteoarthritis, right? So now you've got the valgus foot, right? You have the patients, let me go back to this picture. So you've got this tends to, the medial malleolus tends to shift downwards, the foot rotates out, right? And then you have lots of pain on the medial side of the foot, right? If you guys remember the valgus foot that I showed you yesterday, a lot of weight then is then put on the patient's medial arch, right? And just causes a lot of osteoarthritis. Okay. So, the one thing that you always have to remember is, if a patient presents to you with a pronated foot, which means that they look like they have flat feet, but the foot just seems to be sagging right there in the middle. Look at your patient's demographics, look at the history, and then that'll tell you, give you a little indication of what else is going on with the patient. Questions or comments? Okay, so this slide talks about the too many toes sign that we just discussed. And look at that red line, which shows how the Achilles tendon would normally align midline with the middle portion of the calcaneus. In the case of the collapsed foot, then it's a little off, right? As the foot goes into abduction. So, this is a case where plain films are absolutely necessary, right? And so what you want, question. For a patient that presents to you with what looks like a collapsed foot, what type of x-ray would you order? And lateral. So he says lateral.
Weight bearing.
All right, you totally redeemed yourself here. Okay, so weight-bearing film, right? So foot problems. If I teach you nothing, and you remember nothing that I taught you, I know you remember nothing that Labros taught you. But remember this, okay? If you're going to take x-rays of the foot for a condition of the foot, get weight-bearing films. You cannot go wrong with weight-bearing films. If you send us a patient in ortho with non-weight-bearing films, you're a bunch of unhappy people, and then call you and tell you that you did it wrong, right? Okay. And again, from our x-ray tech, you have them give you proper lateral films, right? And you can rely on your x-ray techs to do that for you. In some cases, if the posterior tibial tendon is grossly inflamed, or if we think that there is some other pathology going on with it, it's soft tissue, then you can get an MRI. Other than that, plain films tend to be sufficient. So how do we treat this? Just like we treat any other orthopedic injury, right? Give them some NSAIDs, activity modifications, right? In some cases, based on how terrible this thing is and how it impacts the patient's lives, then they may have to be put into a brace or short leg cast, right? The inflammation of the tendon sheath, called tenosynovitis, can be very debilitating for a patient, okay? And if the tendon isn't working well, which means that their gait is off, means that they're weight bearing, they have pain with weight bearing, then that significantly affects their daily lives, okay? Now, if I do not advocate injecting the posterior tip tendon. Some people do, right? When you get to phase 2, when they talk to you about it, ortho might do it based on what's going on. But sometimes there's just too much at stake for you to do that in primary care. It's not something that we advocate that you do. When non-operative management fails, then it's time to refer them to orthopedics, right, or to podiatry. And in that case, then, we can do a range of things, right? We can fuse joints, we can, cut the diseased part of the tendon out, graft it with other parts of the tendon we harvest from other parts of the body that helps. Again, I'm not going to test you on anything that says, what orthopedic surgical procedure would you do for this, right? I think that is beyond the scope of us in primary care. But you do need to know when to refer to ortho, and you do need to have an idea as to exactly what ortho is going to do. Okay. All right, questions or comments on this? It is unlikely that you would be putting on a cast in your clinic, but if you can learn this technique, it will help you tremendously in your practice. Okay. Sesamoiditis. Where are the sesamoid bones? Say it out loud so everybody can hear. They are in the first metatarsal, but where in the first metatarsal? The head or the base? It says in the head distally. No, it's not in the head distally. Right? But you're right, it is in the head, just not distally. Okay. All right, so the sesamoid bones are located. They're encased in the tendons that run along the first metatarsal head, right? And so remember we talked about metatarsalgia, and I said if it's in the hallux, if it's in the first metatarsal, then there's a different condition, and this is that condition that we talked about. And as you can see, right there at the head of the first metatarsal. Okay. Now, in cases where there is widespread or chronic sesamoiditis, that can lead to actual decaying and death of the bone, right? Or necrosis of the bone. That's called osteonecrosis. In cases where this is all necrosed, the patient will come in, extreme swelling, lots of pain, absolute pain with weight bearing. You can tell that they walk in with an untied gait, right? The physical exam is going to be almost unequivocal, right? But you won't know that there is osteonecrosis until you do a different exam, either an MRI or a bone scan. What did I say about bone scans yesterday? About their sensitivity and specificity.
Sensitive but not specific. Sensitive but not specific.
They are very sensitive but not specific. So, will a bone scan tell me whether or not a sesamoid bone is undergoing osteonecrosis? No, you're absolutely right. But it will tell me that something is going on in the bone. If I wanted to know whether or not that bone was subject to osteonecrosis, what test would I have to do? Do an MRI, exactly. Right? Or you can cut it open and take a look at it. But you do an MRI first, right? Okay. So sesamoiditis is much less common under the lesser metatarsal heads, right? But remember, when I say it's much less common, it means that it can also happen in those areas, right? However, these bones are very, very infrequently found anywhere else but at the first metatarsal, okay? So, we talked about those clinical symptoms. Dancers, people that do a lot of break dancing, who are up on their toes a lot, they tend to have a whole lot of pain with this, okay? And the more they use their feet or the more they flex their toes, the worse the condition gets. So when they come see you, then either the height of their pain or their situation, then it's easier for you to make the diagnosis, right? But in some cases, a lot of folks just rest off and then they go back at it when they're pain-free. All that does is just prolong the condition and makes it now a chronic situation for them. On physical exam, yes, they'll be tender at the region of the sesamoids. Range of motion may be restricted with pain, but sometimes if you do your passive range of motion and they can grind through the pain, then you realize that they really don't have full range of motion. Now, if the brevis tendon that encases the sesamoids is too inflamed, then that does truly restrict their range of motion. Okay, it's a good picture here. Some people like drawing on their patients. I do not. Some patients don't like it, especially if you use permanent ink. They really don't like it, right? But this just kind of helps to underscore where these sesamoids are located. Okay? So, plain films will tell you if the bones are there and whether or not they have that normal variant called a bipartite sesamoid. Okay? It just means that instead of having one sesamoid bone, now you have two. Okay? It's not abnormal. It doesn't take away from the function of the range of motion of the toe. It just means that you've got a certain subset of the population that has two sesamoids instead of one. If you see this on X-ray, right, and you cannot tell whether or not it's a bipartite sesamoid or if they have a sesamoid fracture, what would you do? Before you consult, that's the wrong answer, but before you consult. Okay, before you ask the radiologist, then you have to order what? Remember, you just saw it's an X-ray, right? You can get, well, you could, right? That sesamoid view just gives you, it's the X-ray view that gives you the perfect view of the sesamoid. But now you want to differentiate, and this is your clinical dilemma, right? You want to differentiate whether this is a fracture or this is just a normal variant. What would you see in fracture? You're not getting off the hook just yet. Normal variant, right? Would it be painful or not painful? Okay, and if it's not painful, then is there a test? If it's not painful, means that it is inflamed or not inflamed? Okay, all right, we're getting closer. So it's not painful, it is not inflamed, then is there a test you can order to help you differentiate? I see you trying to help them out. Is there a test you can do to determine whether or not it's pathological or not?
Comparison to the lab, sir?
Not the lab. Huh?
Comparison view.
I feel like I'm asking you guys a loaded question. All right, I'm just gonna give you the answer. Go ahead. What did you say?
Comparison view.
You do comparison view, exactly, right? But then you do a comparison view and you see the same thing on the other side. Now what? It's a normal variant. Now, if the patient is painful in that area, right? You don't know what, so this was for a non-painful assessment. So you see how we walk through, patient presents, you do your exam, they have this thing, you determine that, oh, there's two of these things. This is a fracture, is this like truly, this patient doesn't have it. Now what if the patient presents with some pain, right? You do your x-ray, you get an x-ray, and then you see this. Can you tell that that is a bipartite sesamoid or a sesamoid fracture? Shout it out, let the friends hear you. What'd you say? It has clean edges, right? It has clean edges, so it's likely a bipartite sesamoid. That's one way you can tell, right? However, Let's suppose it's equivocal, right? You can't tell if the edges are clean or whether they might be a little jagged, right? So now, I want to just lead you into the question, right? So now you have to order another test that will differentiate fracture versus a bipartite test. Which test would you order? I'm just gonna go back to day one. All right, what you say? So you order a bone, that's what I thought I heard. So you order a bone scan, right? What would happen on the bone scan if this were a normal variant?
Well,
Nothing,
you said they have
exactly.
pain
Well,
there. You said they have pain there, though, right?
yes. Right? So if they have pain, the bone scan won't be hot, right? If they have no pain, then you will see nothing, right? Now, they could have other conditions going on in the toe in which, that can be a little painful, but without this being inflamed or hot on the bone scan, okay? So just bear in mind that some of these things present in a manner that makes it a little difficult, which is why it's part of this course, right? Very common. The bone scan, if it's hot, will tell you that maybe there's a fracture or maybe this thing is inflamed, right? But if you order a bone scan and you're absolutely right, there is nothing there on the bone scan, then you can reasonably assume, even if the patient has some pain in the area, that it is a bipartite sesamoid. Okay? I believe your book tells you that the bone scan is definitive for determining this, right? I would bet to argue with the author, right? He wrote the book, I didn't. However, I think an MRI would be your best bet, right? Because the bone scan is very sensitive, not specific. So if I ask a question sort of like, hey, what is the most definitive test for this? And you see bone scan and MRI as answer choices, what would you pick? MRI, exactly. Again, you refer to ortho or podiatry if your non-operating management fails, right? And in the case, remember the heel pads and the little orthotics that I showed you for the metatarsal, right? To offload the heads of the metatarsals, you could use the same thing to offload the sesamoids as well, right? Just be careful, because sometimes it causes more pain. And when all that works, when all that fails, then of course, we get to surgery and you just remove them. Right? Okay. Making sure in the process that you wear the right shoes. Yes, sir.
So would it be common to just remove the sesamoids for diabetic patients with neuropathy or parental ulcerations, especially over since it's weight bearing?
That is an excellent question. His question is, would it be better to just, if I have a diabetic patient with peripheral neuropathy and they have sesamoiditis, would it be better to just remove the sesamoids? It depends. What you say?
Would they even feel it?
They may or may not, right? Depending on where it is and how deep the infection
That
goes.
can cause healing problems.
See?
That can cause healing problems too.
It will cause healing problems, so we are very reluctant to operate on diabetics, right? So most ortho folks, it doesn't mean that we don't, but most ortho folks will tell you that you go through an entire workup, look at their sugar levels and a whole bunch of things before we operate on diabetics. Yeah. Diabetics are not the folks that you want to do routine, non-necessary procedures on. I say not necessary, non-emergent procedures on. Because their healing process is just, it's terrible, right? And you may do more harm than good. Okay, that takes us into a series of toe deformities, right? We talked about conditions of the metatarsal head, right? We talked about conditions of the sesamoiditis, which is in the great toe or the big toe. In some of these other toes, now there are other conditions, and I want you to take a look at this chart here, right? I'll go over it once, but I will hold you accountable and responsible for the information therein. You have been the only one. Doesn't mean it's gonna be on the test now. Just saying that you need to know. So these conditions, right, the mallet toe, the hammer toe, and the claw toe. Most of these, other than some other conditions that cause them, are usually caused by improper and ill-fitting shoes. So, just like with any of the other toe conditions, what is your first thing that you want to advise the patient? Get the shoes, right? If he or she likes wearing tight-fitting shoes with a narrow toe box and high heels, change it or just don't do it as much, okay? Now, all of these conditions affect the metatarsophalangeal joint, the PIP and or the DIP. So I want you to listen up really carefully, okay? In the case of a mallet toe, right? This on the top right picture. In the case of a mallet toe, the DIP, the distal inner phalangeal joint, which is the joint that is closest to the end of the toe, that toe is locked in flexion. Okay? That toe is locked, that joint is locked in flexion. There may be a little bit of extension at the MTP, right? But the fixed flexion is what really differentiates a mallet toe from the other conditions. For a hammer toe, the DIP is generally not affected, or it may be affected, right? Looking at this picture right here, right? May or may not be affected. However, the PIP, that PIP is locked in flexion. Okay, right here. This is your PIP, it's locked in flexion. Now, the MTP, right, the joint that is closest to the metatarsal heads, right here, that MTP may or may not be an extension. Most cases, it is overtly extended. Now, for the claw toe, kind of speaks for itself, right? And so you've got your MTP in extension, you've got your PIP in flexion, and your DIP in flexion. At some point, we'll start talking about Charcot-Marie Tooth disease, we'll talk about some other diabetic neuropathy and stuff, but just kind of keep that chart in mind, okay? Any questions on that? And the reason that I want you to follow that chart is because even if I sit in and tell you which joint is in extension and which one is in flexion, as soon as you leave, you're gonna forget it, right? Because when you go with DIP, PIP, flexion, extension, I probably lost you guys after we talked about mallet toe, right? But take your time, periodically just glance back at that chart and develop your own mnemonic so you can remember which one it is. That way, when you see the conditions, it's easy for you to remember it yourself.
So when it says flexible flexion for claw and flexible extension for hammer, does flexible mean I can do that movement?
It means that you can move it passively, right? In some cases, the patient, if you ask them to move it, there's so much tissue around it, the patient may not be able to move it, the patient, right? But you can move it if you passively move it. Excellent question. So, with all of these different conditions, the patients present usually with some corn or some sort of built-up callus at the, wherever that toe is in flexion, right? And the reason why that you have the callus where the joint is in flexion is because the top of the shoe tends to rub against it, right, and just continues to irritate the area. Right? Again, we talked about improper fitting shoes and pain wherever the joint is potentially locked in extension or inflection. When you do your physical exam, have the patient stand, right, full weight bearing if they can, and take a mental note of which toes are in extension and which ones are in flexion. Okay. And as with any other ortho exam, you want to do a neurovascular exam of the foot. The patient that is obese, older, overweight, and in which you suspect diabetes, then pull out your microfilament, right, and start doing a microfilament test. You guys remember the points along the foot that you do your testing at? All right, exactly. Thank you. Now, if you don't, look at yesterday's lecture. I'm pretty sure I talked about it yesterday. Unless I forgot and glanced over it. But it's in your lecture, so take a look at it. Okay. So this is your left picture there is the general appearance of the claw toe, middle, hammer toe, and then far right mallet toe. Treatment, same as we did for any of the other toe maladies, right? NSAIDs, activity modifications. If they're wearing the wrong shoes, please put them into the correct shoes. So something with more room in the toe box. Okay. You can pare down some of these corns. In some cases, you don't have to, but if you think it's irritating enough, then to the patient, then by all means go ahead and shave those down. Okay. You can use toe splints. Some patients tend to not tolerate these things very well, but if they do, certainly it's something that you can do. And when all of that fails, by all means, refer them to ortho. If you do not treat those, then you got persistent ulcerations, and then they just lead to additional maladies in the foot. Okay. Turf toe speaks for itself. If you played sports, you probably had 1 or 2 or 3. Okay. In those cases, you get some injury to the toe that tends to disrupt the capsule. Usually occurs at the region of the first metatarsal or the first MTP joint, right? And we call it that because it used to be common when playing on artificial turf. But it certainly happens if you're playing in grass and on asphalt as well. Okay. Now, that's why how many soccer players we have in here? All right, you guys are awesome. Right? You play football, I won't hold it against you. It's not a great game, but that's okay. Right? But football players and soccer players tend to get this a lot. It's better now because we have better shoes and cleats. But when we used to play in tennis shoes, then you'll see this a lot, right? And so you get it from injuring the toe while you're running, right? Or when you're trying to kick the ball, and just takes you out of the game. You have to determine when and at what point you want that patient to get back into the game. That you as a primary care PA, that's your job, right? So, when do you get them back into the game? It all depends on your physical exam and the extent of the injury. So, in cases where you determine that they have a grade 1 strain, then they can continue playing because all it is just a stretching of the capsule, right? There may be some tears to ligamental structures, or the patient may come in and they said, hey, I cannot walk on this toe, it is so painful. For either one of those, grade 2 or grade 3, then by all means, take them out of the game for a while. Okay? Is it important for you to know which grade is what? Depends on who you ask. If you ask me, I'm going to say no, right? Just have a general idea of the extent of the injury. Okay. Let that patient tell you, or let the patient's condition help you with your diagnosis. Typically, if you see a patient come in and the big toe is all big and red and swollen and ecchymotic, then you're not gonna put him back in again. Okay? Young kids, you have to be, especially high school players, football players, be very wary. They will almost convince you that this big fat swollen toe that cannot fit into the shoe is not that big a deal. Well, I can walk, I just have to take a day off, right? Protect the patient, sometimes from themselves. Now, if you don't take care of this and you just let it go, then what you have is that condition we talked about yesterday, which is hallux rigidus, right? Because that MTP becomes swollen, it becomes osteoarthritic, and suddenly it starts fusing on itself. Now you can't move it. Your big toe accounts, just like you found, accounts for a significant portion of your gait and stability in your foot, right? Which is why we tend to not harvest any bones along the big toe when we're doing reconstructions, right? So, on physical exam again, look at toe range of motion. If you can't determine what's going on with it, get an x-ray, that doesn't work, then it's appropriate to order an MRI as well, okay? Treatment is exactly what we do for the other toe situations, right? Get them in a shoe that prevents them from bending the thing. Okay. So keeps the metatarsophalangeal joint nice and straight. Protected weight bearing, sometimes they may have to be either in a hard sole shoe. I would not necessarily put them in a cast, but I've seen, based on the patient's activity, that they may be casted for this, right? I think that's overkill because now you've just immobilized an ankle for no reason, for reasons that you don't really have to. Okay, so here are all the things we talked about. Plantar fasciitis, metatarsalgia, plantar warts, posterior tib dysfunction, toe deformities, and ending on the turf toe. Go ahead, take 10, come back, let's do this all over again for another hour. Right, one of the questions we had about the diabetic that had the sesamoids removed, right? So when you dive deeper into the question, it's, hey, this patient is diabetic, right? They've got repeated microtrauma to that area. They've got some ulcers underneath. It's probed all the way to the bone. How often is to remove the sesamoids to help offload that pressure on the foot? The frequency as far as how often it is, I don't know. I couldn't tell you. But what I do know is that it's both a prophylactic and therapeutic operation, right? Because what you're doing is removing the thing that is causing the pressure on the bottom of the foot, right? And you're preventing additional pressure by removing it because now you have less pinpointed surface, you have more broadened surface area for the foot to rest on, right? So you may see that if you encounter diabetics in your practice, they may tell you they had the surgery done, but that's a reason to remove them as well, right? In cases where the sesamoids are just absolutely painful and causing issues, we remove them without damaging the actual function of the foot. Okay, let's talk about little people. So pediatric patients, and they're not just little adults, right? And so their conditions can be unique, right? In a lot of cases, and in some cases, if you miss them, they can lead to potentially catastrophic results as these patients continue to develop and grow. Okay. So we talk about the os trigonum, we talk about the accessory navicular, calcaneal apophysitis, the cavus foot, right? And then we'll close that up with the club foot. In the case of the os trigonum, it's actually just an accessory bone at the back of the calcaneus, between the calcaneus and the tibia. And you will see that a lot in patients that spend a lot of time on their toes, so dancers and ballet dancers, soccer players, and so on and so forth, right? It is a normal variant. Some people will mistake this for a fracture, and then they send it to orthopedics because they have a calcaneus fracture, or they think they have a calcaneus fracture. It is not. In some cases, it actually does not bother the patients at all until later on in life when they spend more time on the toes. Okay? So that pain can be very extreme, especially if as that accessory bone maybe shifts a little bit across its location. And so if it's causing them that much pain, then that's when they will come in to see you because it just hurts for them to do their daily activities. Plain films are great for identifying these. And again, because you're looking at something in the posterior aspect of the foot, then a lateral view is where you will show it on, right? Normally, when you order x-rays, you don't just order one view, okay? So even if I say here you see it more prominently on the lateral view, you tend to always want to order a AP and lateral at a minimum, right? How do you treat those? Well, activity modifications is one, so you stop them from doing the offending activity. Well, after, you've got a patient who spent lots of time learning to dance, right? And to tell the patient now that he or she can no longer dance for, weeks or months, that doesn't go over too well, okay? But NSAIDs and some physical therapy certainly helps. In the case where it's absolutely debilitating, then you can help to immobilize the ankle so that they're not causing too much more trauma. In the case where non-operating management doesn't work, then you send them to ortho or podiatry, and then we can just remove that ossicle. Okay. Same thing for the accessory navicular bone, right? And you see that right here at the navicular itself. As in the os trigonum, this is a secondary site for ossification, right? But it is the attachment for the posterior tib tendon, right? The same tendon we talked about with the too many toes sign. It may become prominent, and as you continue to exercise or to engage in aerobic activity, and the posterior tib continues to pull on its attachment here at this location on the navicular, then you have a more prominent view of that accessory ossicle, right? So in some cases, x-rays are not even necessary for you to diagnose this, but certainly they can be helpful. In other words, do you always have to order x-rays for every condition of the foot? No, you do not, right? This is one of those cases because once you see that and the patient is tender and given their history, then you know that they have an accessory navicular bone. Modifying their shoes certainly helps a lot, right? In some cases, this could actually be a little bit mobile, which makes you, if you're not looking for it, it'll make you question like what is in there. Is it a cyst? Is it, just some sort of hard bony structure of some sort? But in most cases, that's all it is, right? They may have some tenderness there. They may have some pain when you ask them to stand on their toes. But nonetheless, this is a telltale sign, right? This bump on the inside of the foot, on the medial aspect of the foot, that they have a prominent accessory navicular bone. Again, x-rays are not always necessary, but when you get them, it's making lateral and oblique view is what will tell you or give you a good indication of where these things are. How do you treat them? Just like we treat all the other conditions in the foot, right? So NSAIDs, activity modifications, modify your shoe. Anything that tends to want to bump up against this thing, then certainly you want to make sure that the patient is not subjecting themselves to this. And when all non-operating management fails, sounds like a broken record, refer them to orthopedics or refer them to podiatry. Calcaneal apophysitis, this is called Sever's disease. And we talked about the Achilles tendon as it inserts on the calcaneus, right? That ossification center is can commonly, especially in kids that start playing early, then it gets a little irritated, gets a little inflamed, and as you continue to do these jumping and running sports, every time you plan to flex your foot, the calf pulls up on the Achilles tendon, the Achilles tendon pulls on its attachment. That attachment is at that secondary ossification site, right? It pulls it away from the rest of the calcaneus. Did you guys cover Osgood-Schlatter's disease? Okay, so this is similar to Osgood-Schlatter's, just that it's in the calcaneus, right? Usually, we talk about, young kids, but in this age population, at least in some recent studies, to early teenage boys and girls, that's where you will see this. Normally the patients will present with, hey, my heel hurts, I can't walk on it. You'll see them limping, you'll see them walking on their toes because they don't want to put their heels down. But that compounds the problem because for you to walk on your toes, that means you have to contract your calf, right? It makes it even worse, it makes it difficult for them to walk. Telltale sign is that point tenderness at the calcaneus level, right? If you do an x-ray, you may or may not see anything going on here, right? Because it's an ossification center, which means what? That until it's fully ossified, you're gonna see that line that looks like a fracture line. So when you see this in a teenager, a young teenager on an x-ray, doesn't mean that they have a fracture. But if they're painful and you see that, then that should tell you that there is something going on. In some cases, you don't know exactly what is going on, but you can tell that there's something going on there, which is why you consult your buddies or you send it to a specialist. Okay. Again, non-operative management, NSAIDs, activity modifications, change the shoes. When it's really, really bad, okay, then we put them in a cast, more than likely with the foot in neutral. Okay. When all of that fails, then you can send them to ortho, and then we'll do some special procedures on them. Right. Earlier on, and I try to spend some time going over the different ranges of motion of the foot. So this is where this kind of comes in over the next couple of disease conditions. The foot that you see here, right? What is abnormal about this foot? Anybody? It has a high arch, right? Okay. Is it pathologic for a patient to have a high arch? What do you think?
Yes.
Maybe. Right? Like that, yes, that's definitely not right, okay? But you also see some patients that have high arches and they do very well, okay? So just as pes planus is it can be a normal variant, but so can a high arch as well. That is called a cavus foot, which means that that arch is formed into sort of like a cave, so to speak, okay? So in the case of that picture you see on the top here, there are several things going on with that patient. And then the one you see on the bottom, look at the right foot, there's even more going on. So I'm going to walk the dog with you on this for a little bit and then see if we can come to a common understanding of what's going on here, right? So a cavus foot is, all that means is a high arch, okay? We talked about valgus and we talked about varus, right? A valgus foot, what do we say about a valgus foot? Right? You guys remember?
Flat feet.
No, the valgus foot is really not a flat foot. What it means is if you look at the ankle, right? If you apply valgus or varus stress, when you talk about the knee, and I'm sure Davalos went through that with you guys. When you apply valgus stress to the knee, it bows outwards, right? If you apply varus stress, it goes the other way, right? So a varus foot is one that is curved inwards. right? You look at the alignment of the calcaneus, the posterior, the inferior edge of the calcaneus is actually looking more towards the inside of the medial aspect of the foot. See this? Compared to this foot, where it looks sort of neutral, look at this calcaneus, kind of pointed towards the midfoot, right? Towards the middle part of the foot. Right? Now, what's the other word that I told you for plantar flexion? Equinus, right? So now, you've got a foot that has a high arch, the heel is pointed inwards, and the foot is actually flexed down, like in plantar flexion, right? Yes?
I'm confused. I believe when we talked about valgus before, it's like, we'll just say for knees, it means knees coming inward, but do you mean when you apply like valgus force, it's coming up?
Yes, so you're absolutely right. So a varus foot, right? If you got a patient who's got, who is bow-legged, right? What do you consider that? Are the legs in valgus or varus? In varus, right? Now, if they are valgus, if the patient is not knee, right? Then that's a valgus leg, right? But the pressure that you're applying, and maybe that's where I need to clarify, the pressure that you're applying to get the foot into valgus is a varus stress. Does it make sense? Because you're pushing the foot the other way. You're pushing the joint in the opposite direction. Confused yet?
No, but
Okay. All right, so in this case, you've got the foot in equinus, which means that it's pointed down. We're looking at the bottom picture here, right? It's in plantar flexion, which is in equinus, right? Kind of like when the foot is at rest, when the patient is sleeping. The hind foot is actually here, right? So the hind foot is in varus, which means it's pointed towards the body, and the patient has a high arch. That entire condition is called equinocavovarus, which means that the foot's in equinus, it's got a cavus foot, and it's in varus stress, it's in the varus orientation, right? Now, most children that have these, they either have some sort of neuromuscular disorder, maybe a result of trisomy 18, they have Charcot-Marie-Tooth, they may have spinal bifida of some sort, right? There's always something else going on with them. But there are patients that have none of these comorbidities that may just have a foot that is that's in the cavus position. Questions about that?
Sir,
Yes.
sorry to do that. So that foot that you're describing right there, that's like that's as far down as they can go with full weight bearing. They can't flatten that foot out. What you're saying?
This foot?
Yeah.
Yes. So the question is, with that foot, if that's as far down as they can go with weight bearing, that is the most comfortable position for that foot. So if you try to flatten the foot out and get it to look like the picture above, it becomes very uncomfortable for the patient. Right? Now, the follow-on to that question is whether or not this is always like that, because sometimes this can be flexible, and in some cases it is not flexible, right? So if it's flexible, then you can actually get it into orientation. In some cases, you can. In a lot of cases, the patient may come in like this, right? Standing, and you sort of cannot tell, right? You know, remember we talked about that windlass mechanism earlier, right? That I said I'll save it for later. Well, when you ask a patient to stand on their toes, what happens is the plantar fascia, right, forces the foot to reproduce its normal arch. And in some cases, that doesn't happen. That's when you know that the patient has a equinovarus foot. So one way to tell a patient comes in, they kind of look like this, ask them to stand on their toes. And when they stand on their toes, it kind of looks like this. Then you know they've got a cavovarus foot. So most children, right, may have some other neuromuscular disorder going on, but just remember that there are lots of others that absolutely do not. Their symptoms or their complaints may be that they can't find the right shoes to fit them. They may have pain at the heads of the metatarsals. They may have plantar fascia pain. They may have pain along the heel cord, right? So the Achilles tendon, along the calf itself. It's very frequently they may have some calf pain, etc. But it's just a constellation of symptoms. What you will see though for older patients is that they've started to build up a lot of callus along the forefoot. Okay, so on your physical exam, you do all the things we do for normal orthopedic exams, which means that you look at their gait, you look at them walk, you take a look at it, you touch it, feel it, palpate it, then you do your special test on range of motion. Right? If they have other neurological conditions, you may get that from the history, or you may find that in their records. In some cases, you will actually discover that during your orthopedic exams. Okay? But always look at the alignment, my picture, always look at the alignment of the foot. If the foot doesn't look something like this, right, you'll have an index of suspicion that something else is going on with it. Okay. Questions? All right. Imaging. What you want to do is to make sure you get a good AP and lateral of the foot, right? Now, we talked about here, and I think I skipped that in our previous lecture, but looking at the Mary angle, in which that's the angle between the axis from the talus to the first metatarsal, right? You can actually measure that, on your X-ray screen, or ask the radiologist to measure it for you, right? I'm not going to test you on the Mary angle, I don't think. I hope not. Okay. Of course, again, weight-bearing films are absolutely necessary. How do you treat these? Well, it all depends. Just as with any other disease, you want to treat the underlying disorder, right? But when there is nothing else for you to find, right, probably because there's nothing else going on, then of course you do some shoe modifications. Custom insoles and custom arch supports are always great for these patients. But the one thing is that they have to go through physical therapy for good strengthening and range of motion. Okay. When all that fails, then in one backstop, send them to ortho, send them to podiatry. I feel like I don't even need to say that because you guys probably get it by now. I'm going to change my test questions and ask one of these questions to see who gets it wrong, just because. All right. What do we do in ortho? Tendon transfers. We do some osteotomies. It depends on what's going on with the patient. Okay. The pediatric clubfoot. Okay. Now, not every pediatric patient that has a parvovirus foot or something that looks like a parvovirus foot or with the foot pointed inward has a clubfoot. Okay. Now, talipes just refers to foot. Equinovirus is what we talked about earlier. A way for you to remember this is with the acronym CAVE, right? So cavus for high arch, we just talked about this. The forefoot is in adduction, right? The heel is in varus, right? We just talked about that. And the ankle is in equinus, right? Manufacturing. If it's flexible, it's fully correctable. If it's not correctable, then that just means that they have a rigid clubfoot. Some of the other diseases that, besides those that we mentioned, are myelomeningocele and arthrogryposis. That's neuro for you guys. I think if you haven't covered it in neuro, let me know, and I will devise a specialized test question for you just in case. In infants, that deformity may or may not be associated with physical limitations, right? So the kid may be able to run around, you will see them walking on their toes, or they may just have some sort of antalgic gait. If you see that, if you have young kids at home, they continue to trip over themselves, that kind of stuff, and then you look at their feet and you realize that suddenly the kid starts walking on the toes and there is that varus orientation to the heel, then just have them checked out. Okay. Same as your same physical exam as we did in the past for all the ortho injuries, except if it's a young kid, then you have to go back to whether or not they had some neurological congenital disorder at birth. In most cases, plain films can be useful, but it's certainly for very, very young patients, I think the utility is in the physical exam, right, and your clinical assessment, right? But however, if the patient is out and about and certainly ambulating, then by all means get some plain films. But you can get plain films that will help you to see the orientation of the foot, but your clinical diagnosis is absolutely essential in this case. If these are not treated, then this is what you end up with, okay? And so you have this uncorrectable, rigid clubfoot, and they're now walking on the back of the feet, right? Leads to all sorts of knee and hip problems later on. If you catch it early, then it's correctable with a club boot, okay? Custom shoes that you can use for correcting the deformity. All right, any questions? That's good? All right. For very young patients, right, there is the Ponseti method. And what that is you get the patient into a series of casts, right? And every week, you just change the cast out as you try to correct the foot, okay? It's very effective. It is is a go-to method for correcting clubfoot in children. And when all else fails, sometimes you cannot do an Achilles release to help relieve pressure on the foot, but it all depends. Okay. Now, the one thing that I want you to remember is that after you've taken them out of the cast, right, then you also want to make sure that for 3 months they are in a brace. That's all part of the Ponseti technique. When the Ponseti method fails in a young kid, then of course you send them to ortho. If you don't correct this, then you get that picture that I just showed you earlier. Okay. Here in the United States, unless you are in a very, very rural area, there is no reason for a patient to end up like this, right? I think our healthcare is advanced enough that even your junior PAs, NPs, and docs will recognize clubfoot and know that you have to do something about it. So you don't see this probably. All right, so we talked about all of these things. Do you have any questions or comments? All right, we'll make a deal with you guys. Let you go now. No? You're not? No. I thought you said no.
What's the other half?
However, that would mean that I have to catch up on the other half of my lecture sometime in the next 2 days. The good news is the lectures for me are in the morning, and then I think we have something on Friday. But tomorrow and the next day, they're all morning lectures.
No.
You guys ready to go now? Sayonara.